America faces no greater threat to its growth and prosperity than our uncontrolled national debt. Currently, the country's debt exceeds $16 trillion. We're passing this amount of money on to our children and grandchildren to pay off. It's simply far too large of a burden to be placing on our grandchildren and children. As we move forward, it is clear that we must discuss spending. I know that President Obama is hyper-focused on increasing taxes, part of the deficit reduction proposal. However, if we're serious about reducing our debt, we must talk about spending, not sometime next year, not only after we talk about taxes. We must talk about our spending and talk about it now. We need to have a thoughtful conversation that focuses upon where our federal spending most calls for control and containment. I'd like to begin by drawing your attention to this chart that we'll put up here. This chart from the Congressional Budget Office, so it's not something I've put together, details non-interest spending as a percentage of gross domestic product. We already know the significant role health care spending plays in our budget. Over the next decade, the federal government will spend over $7 trillion on Medicare and $4.5 trillion on Medicaid. Together, these two programs account for 1/4 of the entire federal government spending throughout the next 10 years. But look closely at an even longer-term projections of our spending. You have health care spending here growing over the next 25 years. You have Social Security relatively flat, and you have non-interest-bearing spending up and down, but fairly even. But you can see the tremendous growth over the next 25 years in health care spending, which is growing very rapidly as a percentage of GDP compared to, or as a percentage of budget as compared to the other two categories. So let me repeat that. The middle graph, which is Social Security, as a percentage of GDP, will remain relatively stable over the next 25 years. Non-interest-bearing spending, which is the bottom graph, as a percentage of GDP, will also remain relatively stable over the next same period. Now, if you look at the top graph, over the next 25 years, spending for health care entitlement will be basically double as a percentage of GDP. And I'm just now reminded that I said at one time this was a percentage of the budget, but in both of my explanations, I should have said as a percentage of GDP. Mr. President, unless we take a serious look at health care spending, we aren't genuinely acting to reduce our country's debt. 25 years, as this chart looks ahead, is not a lot of time. It may seem like a lot of time in our lifetime, but it comes upon you very, very quickly. We need to be talking about health care spending and talk about it now, not sometime next year, not just once that we've discussed taxes, right now. In Washington, we can get all wrapped up over semantic terms. Do we need Medicare and Medicaid reform? Should we call it restructuring, reorganization, or maybe call it improving and strengthening? Doesn't matter, Mr. President. The terms that we might use in describing it are irrelevant, and the conclusion is undeniable. We must gain control of health care spending. As we move forward in debt talks, I know a lot of attention will be devoted to taxes and revenue. Those conversations are very important and should conclude with tax policy that fosters economic growth. But conversations about health care entitlements should not be postponed or relegated to some second-tier status, particularly when this very day they amount to about 44 cents of every dollar that the federal government either gets in taxes or borrows. In other words, we spend. And they certainly should not be confined to cost reduction exercises that ignore fundamental cost drivers. And I think that's the most important thing I ought to leave with you, as what I say next will exemplify its importance. We talk about cost reductions, but what's more important in health care is to not ignore the fundamental cost drivers. I have read reports of the savings in Medicare and Medicaid that President Obama has proposed. I'm not finding fault with his proposals. I'm just saying that won't be enough. In my mind, they do little more than take cash out of the system without making fundamental changes necessary to bend the growth curve. Let's take a look at a few of those in President's 2013 budget. There's increasing the income relating of Medicare premiums. That one takes more money from rich seniors, and I don't argue with that point. There is increasing co-payments for home health. This will increase costs to all seniors. Now, that one I might argue a little bit with, but I'm not going to say it shouldn't be on the table. They're getting bigger, there's another suggestion, getting bigger rebates from drug companies, even if it harms Part D. That one takes money from the drug companies. There's cutting provider taxes in Medicaid. That one will take money from states at a time when the administration is encouraging them to expand Medicaid to cover childless adults. As an aside, I noted that the Washington Post had a banner editorial last Friday supporting a reduction of Medicaid provider tax. I wish that the Post had been so helpful in 2006 when the Bush administration made a similar proposal. There is also something called the blended rate for state reimbursement under Medicaid. That breaks the promise to pay for 100% of the cost of those made eligible under Obamacare. Mr. President, these proposals will certainly reduce the federal outlay in Medicare and Medicaid, and so I suppose should be applauded, even if there's some dispute about them. However, these proposals will not solve the larger problem of health care spending growth, the growth that we're talking about here in the top part of this chart. Instead, we should also focus on where our spending really is taking place. I'm fully aware that there is significant opposition from Democrats to Republican ideas like premium support for Medicare and block grants for Medicaid. I'm not here today promoting either one of those ideas, but opposition to those ideas should not allow Democrats to walk away from this issue of changing or of stopping this, or of, I should say, of making fundamental changes that stop this growth that we're having here, a growth that we can't sustain. We must address the growth of health care entitlements, in other words. I believe our Medicare and Medicaid spending problems can be explained in three straightforward charts. And we'll put those charts up here, and I'll go into depth about those charts. Here we look at federal Medicare and federal and state Medicaid spending divided into three groups. On the left is spending by the federal government for people who are eligible only for Medicare. On the right is federal and state spending for people only eligible for Medicaid. In the middle is the federal and state spending for people eligible for both Medicare and Medicaid. These folks are sometimes described as dual eligibles, or sometimes just by the one word, duals. This middle group, the duals, account for just over 10% of the entire Medicare and Medicaid population. However, there is more spending on duals than on Medicare-only beneficiaries and Medicaid-only beneficiaries. When we talk about the need to find ways to control spending on duals, it is for a good reason. We must find ways to realign the disparate incentives of the federally run Medicare program and the state-run Medicaid programs. However, focusing on solutions exclusively to the dual eligibles misses the fullness of this problem. For one, the dual are not an homogeneous population. While most people consider people on Medicare to be typically elderly, fully 30% of the duals are non-elderly. Also, while many of the duals are clearly high cost, there are a larger number of duals who utilize very few services. So while the improvements to the care model that we use for duals are necessary, they are far from sufficient in reducing the totality of the growth driving health care costs. We have another chart. In this chart here, we find the most expensive individuals in the Medicare program. This is a population who has 2 to 3 chronic conditions and functional impairments. Among the most expensive Medicare beneficiaries, more than half, as you can see, 57%, qualify for only Medicare. Providing better coordinated care and reducing costs for high-cost beneficiaries is critical for the future of Medicare and Medicaid. I have strong reservations about splitting these two groups based solely on individuals' income. Proposals that give the states greater control over acute care services for the 43% who are duals essentially divides two similarly situated, expensive individuals between one federal model and 50 different state models based solely on their income. This makes no sense. A Medicare-only beneficiary may exhaust income and assets and become dually eligible. The separation between the two populations is arbitrary as well as artificial. Whatever we do to find a better model to coordinate care and reduce costs for high-cost beneficiaries, we need to address all beneficiaries, not just the dual eligibles. To find rational solutions to our health care spending, we must first accurately target the populations who incurred the most significant expenditures. This includes individuals who are not only the duals, but also those Medicare-only seniors with multiple chronic conditions and functional impairments. Finally, I'd like to draw your attention to my last chart. This chart details spending on long-term services and supports for the year 2010. 2 years ago, a total of $208 billion, 8% of all U.S. personal health care spending, was spent on long-term services and supports. Among this spending, Medicaid, the single largest payer of such services, picked up 62.2% of the cost, while the private market paid for just over a third of this total cost. With 80 million baby boomers entering retirement age and 7 out of every 10 seniors needing long-term care at a certain point in their lives, the demand for those services will only increase and further drive health care spending if we don't take action. We must find ways to increase private spending and decrease public spending on long-term services and supports. If we're going to argue that we are reducing the growth of health care costs, we must then, as people expect, actually do it. So, Mr. President, in closing, we have an opportunity before us. We can either make real changes in our health care entitlements that will impact the growth curve for years to come, or we can simply take cash out of the system and call it reform, as the President proposes. and members of Congress proposed that as well, so I don't want to just blame the president. We have to be willing to re-examine the effectiveness of our current overall Medicare and Medicaid structure. We should not be afraid to ask tough questions. Should Medicare and Medicaid be structured in a way that provides benefits to individuals in the most efficient and effective way possible? Are Medicare and Medicaid, in fact, structured in a way that guarantees we spend federal and state dollars inefficiently or ineffectively? When you look at the spending on duals, the spending on high-cost beneficiaries, and the spending on long-term support and services, I believe the answer to both questions is yes. In other words, the money being spent is spent inefficiently and ineffectively. Medicare and Medicaid proposals must address these three concerns. President Obama hasn't come to the table yet. I know that there are people telling us we shouldn't talk about health care entitlement now. We don't have a choice. Look at the numbers that I put up in the first chart. Look at the spending. We only make the problem worse the more days or years that we put it off. We can save federal dollars by extracting more from beneficiaries, providers, and states, but that won't bend the long-term growth curve. We have to talk about solutions to actually lower the growth curve and talk about it right now. We are $16 trillion in debt. 1 out of every $4 that we will spend in the next decade will be on Medicare and Medicaid. We will see health care entitlement double as a percentage of GDP in the next 25 years. If we want Medicare and Medicaid to not only survive, and I think it's part of the fabric of America, but also thrive for the next generation, and we should want that, we need to be willing to ask fundamental questions and seek solutions that can affect the growth curve. I sincerely hope that we will be willing to look for solutions that can make a real difference, and I intend to come to the floor a few other times in the next few weeks to discuss this issue with my colleagues. I suggest the absence of a quorum.